Thank you, Dr. Laniel, for the invitation to speak, and thank you to all the attendees. When you go third, you have an easier job because both of Dr. Bowman and Laniel already set the stage in terms of some of my targets. So, I think what I'm going to try and do is put it a little bit into context of this and not talk about the unique common toxicities in terms of ICANS and CRS, but speak more specifically to these agents and some of the unique toxicities that we see in management strategies. So, I'm from the City of Hope in California, and if you remember during COVID, there were multiple pictures of the beaches in California that our entire city seemed to flock there. It's in a way, it's sort of what we say about myeloma. So many drugs, so crowded a space. But actually, you look at that same beach just from a different view at the same time of day, it's actually pretty empty. And it's sort of the same way for our myeloma patients. If you blow through the classes of drugs that Dr. Laniel had talked about in terms of PIs, IMiDs, CD38 antibodies, and what Dr. Boomer has addressed, BCMA antibodies, the space is actually pretty empty and clearly new targets are needed. Next slide. So I'm going to focus, Dr. Boomer focused very elegantly on the top list there in terms of BCMA. I'm going to focus on these other targets. So Dr. Lonell had mentioned GPRC as a target in myeloma, and I will speak about talquetamab and farinmatig. And then he also mentioned FcRH5, another unique target expressed on B cells and plasma cells. And again, I will focus on cevostamab's data. Next slide. So in terms of our case, this was a 74-year-old male presented with left buttock pain, found to have extensive lytic disease um, in the sacrum, accounting for this, had a marrow at 414 and 1Q gain, lambda light chain disease. He had what was pretty standard therapy back when he was initially diagnosed with triplet induction and an autologous transplant. And because of the 414, he was given lenalidomide maintenance for several years. He had a bipanel progression, and because he was CD38 naive, he was then treated with a CD38 Lendex combination with somewhat minimal response, was switched to another IMiD, so in this case, pomalidomide, had initial response but progressed after about 4 months. He was then enrolled on teclistamab as a clinical trial and had a complete response for 9 months. Progressed and because he had been carfilzomib naive, received a carfilzomib-based combination, um, but did not respond, received selinexor with 1 cycle with no response. I should add at those times, some of these choices were based on also limitations in terms of access to CAR T. He then got an FcRH5 on clinical trial, achieved a complete response, progressed again, and at this point received BCMA targeting CAR T cell therapy, but had no response. Next slide. And so we did sequencing on him, and we found it was not surprising that he had no response to BCMA because probably driven by the teclistamab, he indeed had 10 separate deletion events on the BCMA target. And in fact, 85% of his cells had a biclonal deletion. So that suggests two things in terms of how we manage these patients. One is obviously in terms of now with these targeted therapies, we really need more information about targets before we select the appropriate one for these patients with advanced disease. And certainly we are launching an initiative to be more thoughtful and to look at least in the research context, doing whole genome sequencing on our patients who have advanced relapse disease for whom we plan T-cell directed therapies. Next slide. So GPRC, as Dr. Laniel mentioned, this is another target in myeloma. It has high expression on myeloma cells. It has a very high activity, as you can see in mouse models. But let's also focus on some of the other places where GPRC is expressed, and some of that is in hair follicles and keratinized tissue and salivary glands. Next slide. We were participants in this Monumental 1 study, the phase 1 study of talquetamab in advanced relapse myeloma. Again, very similar entry criteria to what Dr. Bummer mentioned with teclistamab, so I'm not going to go into that. But you can see here in terms of response rates, 60 to 70%. This drug was presently given on both weekly and biweekly schedule in this initial trial, and certainly moving ahead in clinical practice, most of us are using the biweekly schedule. You can see that the 12-month PFS was about 50%, though lower in patients who had had prior T-cell engager therapy, and we'll discuss that. You can see depth of response was certainly very promising as well, with some patients even achieving complete response, the majority achieving a very good partial response. And this didn't seem to correlate with the extent of GPRC expression. Next slide. I think one of the most interesting things, and this will be when we talk about management of side effects, it is that we also had a look back at this monumental cohort and looked at patients who underwent dose reduction, because this is really one of the most common ways that we manage the side effects that I'll get into, specifically dysgeusia. Now, I should caveat that in the trial, patients had to have a partial response or better, and dose reduction was after 3 cycles. And you can see here that this was the biweekly patients could go down to even every 4 weeks, and the weekly patients to every 2 weeks. Next slide. And you could see that even with this prospective dose reduction, patients were able to maintain a response with, again, that 12-month PFS very much mirroring the original group at 50%. Next slide. Um, Now let me talk about furingmatig. Furingmatig is also GPRC binding bispecific, but it binds to 2 targets on the GPRC epitope. And the hope with this is that you can perhaps get away with using a lower dose and therefore minimize some of these on-target off-tumor toxicities, specifically the dysgeusia that we see in about 60% of patients. We also see skin and nail toxicity in about 70% of patients. That can be in terms of patients losing fingernails, exfoliation of the skin on the palms and soles, and skin rashes. Next slide. You can see in terms of the phlegmatic phase 1 trial that was presented at ASH a couple of years ago, response rates seem very comparable to what we see with talquetamab, between 60 to 70%. But so far, the side effect profile also seems very similar, with, you can see here, dysgeusia in about two-thirds of patients, again, mirroring what we've seen with talquetamab, and mucosal inflammation in a minority, and also dry mouth, very common. And we didn't list here, but the skin and nail toxicities as well as something we've been seeing. Next slide. Dr. Bama touched on combination therapies. He talked about talquetamab with daratumumab, and showing a response rate that's higher than single agent talquetamab at about 84%. I want to talk about the combination of talquetamab plus teclistamab. And this speaks to something that we didn't touch upon earlier. Certain groups of patients seem to respond less well to bispecifics and also to CAR T cells. But in the case of bispecific, it's patients with extramedullary disease. And we don't know the reason. Is it because of what Dr. Lonell alluded to earlier? Does the body itself set up sort of a microenvironment around these sites that make it harder for bispecifics? to work, or is it just a matter of a bispecific antibody getting into a large tumor mass? Nonetheless, what we did see with redirect one, which was combining bispecific antibodies, that the response rate seems much higher in patients with extramedullary disease. You can see here an 85% response rate with the combination compared to only 35 to 40% with single agent um, bispecifics of either one. So I think this is certainly a very promising combination moving forward. Obviously, we don't know what that means in patients who've had prior tech and talc if, with the combination, if it has any efficacy at all. And I think that's something that remains to be seen. Next slide. Um, but this combination strategy, therefore, is certainly being explored both in terms of the CAR T setting, so dual targeting, but also in the bispecific. Now, I should actually call it a trispecific. And we have here a trispecific, first in class, targeting BCMA, GPRC, and CD3. And we just opened this trial at City of Hope. And I think the unique parts of this trial, it does allow patients with non-secretory disease. So we will see those patients who have extramedullary disease be included in this trial. We're very excited to see the responses with this compound. Next slide. And let's talk about now cevostamab. So Dr. Loniel mentioned that FCRH5 is expressed on B cells at somewhat of a lower level than GPRC or BCMA. And that may in part, therefore, explains the slightly lower response rate. Again, limitations of cross-trial comparisons, but you see the response rate of about 40 to 50% with cevostamab, the FCRH5 targeting bispecific antibody. This drug is given as an IV formulation. It was given in two separate trials, and one trial was given IV every 3 weeks, which actually I actually favored in terms of obviously patients found this much easier. They also gave it as an every week schedule in part to see if that could improve the response rates. So far, the toxicity profiles didn't seem very different between the Q3 and Q weekly schedule. Next slide. But what they did, I think that was really fascinating was two things. Actually, if we can go back to the prior slide, they on the lower left here, you can see they were the first ones to kind of get ahead of the curve and say, how can we lower the incidence of cytokine release? So they had a cohort of patients pre-treated with tocilizumab to see if that did reduce the initial side effect of cytokine release. And indeed it did. It went down to about 38% and didn't, I'm sorry, down to about 30% and didn't seem to have a significant change in terms of response rates. Next slide. I think, though, to me, the most interesting thing that cevostamab did in a planned fashion, and now many other bispecifics are looking at and thinking about adopting, is they gave fixed duration of therapy. So, I think Dr. Bowman sort of spoke of some of the infection profile and risks with BCMA targeting strategy. And so certainly using that in a dose limited fashion would be attractive. I spoke about talquetamab and the side effects of dysgeusia, dose reduction, but even again here, thinking about limited duration of therapy may be a benefit. So when you look at cevostamab, they gave it for 17 cycles, and then patients discontinued therapy. Patients were allowed to resume therapy if they had evidence of disease progression. But you can see here, again, a small number, but certainly a cohort of patients maintained responses um, from up to many, many months off of treatment. And that, I think, to us gave us a very encouraging signal that these drugs may be different from our prior myeloma drugs and that you don't need to have continuous exposure to maintain responses, probably because of the immune activation signals. Um, and perhaps that will also help with some of the other things that I've shown you, such as the selective pressure to and mutational resistance that we've seen with some of these agents. Next slide. And I think to me, this is the most interesting question right now in the space of advanced relapse myeloma therapy. And maybe during a panel discussion, um, we will have a discussion in regards to how we all do this, but how do you sequence it now? We are lucky we have multiple BCMA directed therapies. We have that's CAR T and bispecific, and we have different targets with GPRC. They all have similar indications in the FDA setting of CAR T and bispecifics. Next slide. Um, so Dr. Obama sort of spoke about this, about bispecifics after prior um, BCMA targeted therapy, and we saw this with Majestic 1 and ADC exposed and CAR T exposed. You can have responses lower than the overall cohort. But what we didn't discuss was the progression-free survival does seem shorter. Next slide. And this is the real world teclistamab data. Again, same idea that response rates after prior T-cell directed therapy seem to do better if you wait at least 6 months as an interval before your prior BCMA directed therapy. Next slide. But I think the key take home that we've seen, at least in the real world setting, is that we're better off doing CAR T cells before bispecifics, because you can see here on the left, CAR T cells after prior bispecific therapy, the median progression-free survival is very short, at least about 2.7 months, probably speaking to the T cell health after they've had continuous exposure to a bispecific antibody. Next slide. And here is the talquetamab data in terms of patients that had prior T-cell redirection. Same theme. You can see responses lower in patients that had prior bispecific, 40%, better in patients that had prior CAR T, probably in part because we were changing target, and also in part because of the duration between CAR T and the bispecific. Next slide. Um, and this is again CAR T after talquetamab, as you can see here. This is interesting because perhaps you can do better with CAR T after talquetamab than you do after teclistamab. Again, possibly in part due to target, very heterogeneous groups of patients. It's hard to compare that across trials. Next slide. So in conclusion, T-cell therapies obviously are now a backbone for us with relapsed myeloma. They're being moved into the earlier space, including in the frontline setting, but given in a more fixed duration, combination therapy certainly is something that we're going to see more and more. And we continue to look for new targets and also to be smarter about how we use them and understand and use genomics to understand mechanisms of resistance and how to best sequence these agents. Thank you.